All right, everybody, good afternoon. My name is Irmina Elliott. I'm one of the thoracic surgeons here at Stanford, and I'd like to welcome you to the Junior Investigator Roundtable presentations. Each presenter is going to give a brief introduction of who they are and then talk about their research for about 5 minutes, and hopefully we'll have some time for discussion at the end. So I'm going to call up Jacqueline Aredo first.
Good afternoon, everybody. I'm Jackie Aredo, and I'm a medical oncology fellow at Stanford. I'm very proud to have been born and raised in the San Francisco Bay Area. I grew up around 20 minutes from here. And after a brief stint in the East Coast, I came back for my medical education at Stanford, where I also completed a master's degree in epidemiology and clinical research. And that's where I first was introduced and worked with the thoracic oncology team here. I then completed my internal medicine residency at University of California, San Francisco, before returning to Stanford for my fellowship. And since I've been here, I've been very honored to be able to work with the thoracic oncology team. This is a picture of me with my mentors, Dr. Neal and Dr. Wakely, at our targeted therapies meeting of Santa Monica last month. And my research focus has been two-pronged, first focusing on clinical research on oncogene-driven lung cancers with a particular interest in never-smoking lung cancers, where we've done database analyses, translational studies with the goal of using these data to develop informed clinical trials. And I'll cover a couple of those during this talk. And a lot of my trial development has actually focused on the early-stage EGFR-mutated lung cancers. And we spent a lot of time talking about in the last couple of days, improving methods for screening and early cancer detection. But we also have to have improved methods for treating these patients when these lung cancers are found early. I've also partnered with Dr. Summer Han at the Quantitative Sciences Unit, where I've conducted epidemiological research on lung cancer screening and cancer disparities. And in the next few months, I am planning a cross-country move to Boston, where I will be starting a dual appointment at Harvard Medical School and Mass General Brigham Cancer Institute. So to discuss one area of our work, let me see where I can advance this. Okay, so within the early stage EGFR lung cancer space, one area that I was really interested in was this particularly high-risk patient group, and these are patients with stage 3 unresectable lung cancers. So these patients are not surgical candidates because they either have large bulky tumors or there are a number of lymph nodes involved in the middle of the chest. So instead of surgery, these patients with early stage lung cancers will get chemoradiation. And in the past, over 5 years ago, the standard of care was that everybody who would get chemoradiation would receive a year of consolidation immune therapy. As there was a trial that showed this improved survival outcomes. But the question was always, does this benefit also apply to EGFR mutated lung cancers, where we know immune therapy isn't so effective? So now we know to really distinguish that adjuvant treatment based on EGFR mutation status. But before we knew that, we kind of helped contribute to this literature. So on the top left, here is a multi-center study that we led from Stanford, and this was towards the end of my medical school time in 2021, where we evaluated patients with stage 3 unresectable EGFR mutated lung cancers who received either chemoradiation alone in blue or who received chemoradiation and durvalumab in red. And we saw that there is no differences in improvements in progression-free survival. And instead, these patients who received durvalumab, about half of them would go on to experience some sort of immune-related adverse event, whether it's pneumonitis, inflammation of the lung, or colitis. So there was actually this concern for harm, that we were harming these patients with this strategy. And in this study, we found a small subset of patients who had received off-label EGFR inhibitors, either before chemoradiation and after. And these patients in black here in this plot, these patients had significant improvements in their progression-free survival. And this, was later on supported by the LAURA trial, evaluating maintenance osimertinib after chemoradiation. But we were really interested in those patients who received induction in EGFR inhibitors before chemoradiation. So we followed up this study with a case series here in the bottom left for patients who received either induction erlotinib or induction osimertinib, followed by chemoradiation. And we saw that, out of these 6 patients, only 1 patient had disease recurrence. And a lot of these patients had only received the induction TKI and chemoradiation. Many of them had not received any maintenance therapy afterwards. So kind of hinting that there was this signal of benefit with this strategy. So we followed this set of studies up with the development of what started as an investigator-initiated clinical trial. But there was a lot of interest from the sponsors in this strategy, and so it grew into this global study now. It's called NEOLA, so it's NEOLAURA, but shortened to NEOLA. And Dr. Wakely and I have been involved in leadership for this study. It's a phase 2 trial evaluating induction osimertinib for 8 weeks before chemoradiation, and then followed by maintenance osimertinib indefinitely, similar to the LAURA trial. And our primary endpoint is 12-month progression-free survival. And the study is being conducted across different continents, here in the United States, and Asia, and Europe. And we've enrolled 75 patients with our interim analysis showing preliminary signals of safety. So now we're just following this through to see our primary endpoints, and we really look forward to seeing whether this can be an effective strategy for these patients. Happy to answer questions later. Thank you.
Good afternoon. My name is Carolyn. I'm a general surgery resident, but now in my second year of research with the Department of Thoracic Surgery. Today I'll be presenting some preliminary results on our study called Feasibility of Panitumumab IRDI 800, or PAN 800 molecular imaging for tumor localization for lung cancer. Tumor localization in lung cancer can be challenging, particularly for small tumors that are often resected using minimally invasive techniques. Traditional localization methods can be cumbersome as they can delay surgical resection and can expose patients to additional radiation or procedural complications. Intraoperative molecular imaging is an emerging technology that allows surgeons to visualize tumors in real time. An imaging agent is administered intravenously prior to surgery, preferentially accumulates within the tumor tissue, and produces a fluorescent signal that can be detected with near-infrared surgical cameras. One such agent is PAN 800. Panitumumab is a monoclonal antibody that targets EGFR and was originally FDA approved to treat metastatic colorectal cancer. When given at lower subtherapeutic doses and conjugated to a near-infrared dye, it can function as a fluorescent imaging agent and has been shown to have a good safety profile. While promising in other cancers like head and neck cancers, it hasn't been well studied in lung cancer. So in our study, we have 2 primary aims, which I will go through in the next slide. To first determine whether this target is even relevant in lung cancer, our first aim was to evaluate EGFR expression in resected non-small cell lung cancer specimens. Formalin-fixed paraffin-embedded surgical specimens from patients who underwent lung cancer resection at our institution were obtained, and EGFR expression was quantified using corresponding H&E sections with tumor encircled as reference. And as you can see on screen right, we found that EGFR expression was significantly higher in tumor tissue compared to normal lung tissue. Specifically, expression was 51.8% in adenocarcinoma versus 14.6% in normal lung, and 69.5% in squamous cell carcinoma versus 9.6% in normal lung. These findings confirmed EGFR overexpression in lung adeno and squamous cell carcinoma, supporting the rationale for EGFR-directed imaging. This then led to our second aim, which was to evaluate the clinical feasibility of PAN 800 imaging. So we conducted a single-center phase 1 open-label exploratory study assessing dose and timing administration. Patients with biopsy-proven or suspected non-small cell lung cancer who were scheduled for surgical resection were either infused with 25, 50, or 75 milligrams of PAN 800 1 to 5 days prior to surgery. During the operation, surgeons first use white light, then activate the near-infrared imaging mode for tumor localization prior to proceeding with resection per standard of care practice. In vivo fluorescence is quantified with the intraoperative images that were obtained, and resected specimens then underwent ex vivo fluorescence imaging and EGFR analysis. To date, 15 patients have been infused, with 11 included in the final analysis. There were no major drug-related adverse events at any dose level administered. Overall, 4 patients, or 36%, achieved successful intraoperative tumor localization. The median tumor size in this group was 2.3 centimeters, with a median tumor to pleural distance of 0.1 centimeters. Notably, all successful cases occurred in patients who received either 50 or 75 milligrams of PAN-800 infused 2 to 4 days prior to surgery. So on screen left is just one example of our patients. This is a patient who had a 2.8 centimeter nodule suspicious for primary lung cancer, as shown on the axial image of the CT scan. This patient received 75 milligrams of the PAN-800 and underwent surgery 4 days after. Under standard white light, you can see that the tumor is quite difficult to visualize. However, when we activate the near-infrared imaging modality, the tumor becomes clearly visible through PAN-800 fluorescence. This patient had an in vivo tumor to background ratio, or TBR, of 2.7, and after resection, ex vivo imaging demonstrated a TBR of 4.5, and EGFR analysis is currently ongoing. So in summary, our findings demonstrate that non-small cell lung cancer overexpresses EGFR, supporting PAN-800 as a safe and feasible imaging agent for intraoperative tumor localization. Our preliminary data suggests that 50 to 75 milligrams administered either 2 to 4 days before surgery can achieve intraoperative localization. However, patient enrollment is ongoing to further refine these parameters, and we are excited to have just gotten approval to infuse with a higher dose at 100 milligrams. Thank you.
Hi, my name is Saskia, and I'm a postdoc here in the School of Medicine with Dr. Summer Han, and I'm going to be talking today about how I use real-world health data to improve public health and clinical outcomes. So just a little bit about my background. My overarching goal is that I'm really interested in turning messy real-world data into actionable health evidence. And my approach is that I combine epidemiologic thinking with rigorous statistical methodologies in order to tackle questions where doing randomized trials or experiments is not feasible or ethical. So during my PhD, I used observational data to study maternal and fetal health outcomes, and in the process, I worked on developing statistical methods, specifically Bayesian models, to understand environmental risks in large populations. And now, as a postdoc, I'm applying those same methodologies to rigorously study lung cancer questions, focusing on screening and prevention in vulnerable populations. So I'll talk about some examples of some of that work that's going on in our lab. Cancer survivors face substantial risk of developing a second primary lung cancer. And the data that I'm showing here illustrate a surprising finding, which are that risk factors may differ between first and second cancers. So in the left-hand panel A, that is showing incidence of initial primary lung cancer for smokers, that's the orange line, and non-smokers, that's the green or blue line, I'm not sure the color. And you can see that there is very clearly a stark difference, about a 7-fold difference in cumulative incidence between those groups, as we would expect based on what we know about risk factors for lung cancer. But on the right side, I'm showing second primary lung cancer among patients who already had an initial primary lung cancer diagnosis. And we see that the cumulative incidence is very similar between the smoker and never smoker groups. They have a similarly about 3% cumulative incidence at 10 years. And this is a very surprising finding because it contradicts what we thought we knew about these risk factors. And so in an ideal world, we would study screening and risk factors like this by doing a randomized controlled trial. But that is very challenging for a number of reasons. For one, you can see that the time scales on these axes are multiple years, so it would take a long time, it would be very expensive, and it might be hard to get all of the populations that we're interested in sufficiently recruited in adequate sample sizes for a trial. And it might be unethical. If we think that screening is helpful and necessary, we might not want to randomize people to a no screening arm of a trial. So that's where my methodological work comes in. I work on a set of statistical methods called target trial emulation. And these methods are basically trying to let us use existing patient records to emulate the ideal trial that we would do if we could do a randomized controlled trial. And we try to map that ideal trial protocol onto the data that we have, and then use different forms of statistical adjustment to correct for the biases that we might have in real-world data. And ultimately, what we're trying to do is ensure a fair comparison between patients who are and are not screened, accounting for all of the biases that might come into why someone does or doesn't get screened in the real world in the absence of randomization. And big picture, TTE, target trial emulation studies, are an advancement in lung cancer research for several ways. One of them is that they can help us get faster answers to questions that would take years and years to answer with a randomized trial at great expense. We can be more representative by using patient data from electronic health records that already exist, potentially capturing patient populations that would be hard to include in a prospective randomized trial. And lastly, we can hopefully, and this is the ultimate goal, produce better evidence to help physicians and patients guide their risk stratification and screening decisions going forward. Thank you very much.
Hi, everyone. My name is Alice Guan, and I am a social epidemiologist and a research scientist at UCSF. I work in the DREAM Lab, which is co-led by Drs. Scarlett Gomez, Iona Chang, and Salma Sharif Marco. And my research broadly examines how structural and social environments shape cancer risk. So today, rather than sharing about a specific project, I'll be talking about a sample of work that I've done in the space of tobacco control specifically, and specifically share how these findings relate to lung cancer in never smokers. So, as many of you know, one relatively known risk factor for lung cancer among never smokers is actually exposure to secondhand smoke. And so what I'll share with you today is how I've approached the investigation of secondhand smoke across 3 different levels: at the neighborhood environment level, in the level of the family and social context, and also at the individual level of exposure. So first, I wanted to share about a study that I'm working on at the neighborhood level. One built environment characteristic that has been found to be associated with secondhand smoke is actually tobacco retailer density, which is a measure of how many tobacco retailers are actually present in a specific geographic area. The density of retailers is something that reflects both historical and also contemporary policy decisions, and these include zoning, licensing, and also commercial regulations, but also discriminatory policies, including redlining, segregation, and historic neighborhood disinvestment. Areas with higher retailer density may normalize tobacco use a little bit more and increase visibility of smoking, as well as environmental exposure to tobacco smoke for residents who live in these neighborhoods. So in an ecological study of California, I'm working with Dr. Lisa Henriksen and Dr. Scarlett Gomez to examine the downstream effects of tobacco retailer density as a geographic measure on tobacco-associated cancers, including lung cancer. And while this specific study doesn't focus on never smokers, this work situates secondhand smoke not as only an interpersonal exposure, but as something that's embedded within these structural environments. And second, I wanted to share some work that I've done in the past, specifically examining secondhand smoke within the family and social context. We know that tobacco use prevalence varies actually across communities. Among some immigrant Asian American populations, particularly men with limited English proficiency, smoking prevalence actually remains quite high in comparison to the average population prevalence. And this includes in This creates an important household dynamic where women and children in these types of households likely experience elevated secondhand smoke exposure that could increase their risk for lung cancer despite never smoking themselves. So I wanted to share some work that I did in a past study led by Dr. Janice So at UCSF, where we implemented a lay health worker and family-based smoking cessation intervention that targeted Chinese and Vietnamese American men and their family members here in the Bay Area. And what was critical about this intervention was the involvement of a non-smoking family member as a part of the cessation strategy, which acknowledged that smoking is not only an individual level behavior, but a household level phenomenon. And the intervention was able to successfully engage men who were not ready to quit smoking at baseline to adopt nicotine replacement therapies and also have cessation attempts. And finally, I wanted to shout out the work that I'm currently doing within the Female Asian Never Smokers, or FAN study, that's led by Dr. Scarlett Gomez and Dr. Iona Chang, that you've heard a lot about in the past 2 days. And my work within FANs examines the association between secondhand smoke exposure and lung cancer risk. And so I'm going to continue working on those analyses and refining those for publication. So across this body of work, my intention really is to document the many layers through which one specific risk factor, like secondhand smoke, can actually function and operate in society, whether it's at the individual level, all the way up to the neighborhood level. And all of these could point to different levels of interventions that can be implemented to reduce disparities in lung cancer. Thank you so much.
Hi everyone, I'm Rittwika Kansabanik. I recently joined as a postdoc research fellow at Dr. Samahan's lab at Stanford School of Medicine. Previously, I am graduated with a PhD in statistics. Today, my topic is unlocking real-world evidence in EGFR plus mutant non-small cell lung cancer patients. So, as you already know, for these patients, they go through multiple lines of therapy as resistance emerges, and each of these transition comes with a load of clinically important information, but sadly, often these information are buried in huge volume of narrative clinical notes, and the only method to extract this information for nowadays is manual chart abstraction, which is slow, costly, and on top of it, they are inconsistent and often requires double review. The current research explores using LLM to automate this extraction process, but frequently they focus on single note or static note per patient and lacks temporal reasoning. For this project, our goal is to develop a pipeline where at one end, we will feed this huge volume of clinical texts, one patient at a time, and on the other end, we hope to get a full, clean treatment history for the corresponding patient, which will start with the diagnosis date, will end in the last encounter, and in the middle, there will be different events related to treatment lines, disease progression, and adverse events. All are located chronologically. So these type of timelines often we call patient knowledge graph or clinical skeleton. They are useful in several areas. For example, large-scale survival analysis or creating digital replicas or digital twins, which in other hand, help us to predict the outcome of next line of treatment. Also, we can develop AI co-pilot using this information. So the first flowchart you see here is to get this clinical skeleton or patient knowledge graph. To give you a short idea about it, this essentially is built with two layers of LLMs or large language models. The first LLM will look for all this clinically important information from the texts, and the second LLM scrutinizes these extracted findings and provide feedbacks to the first LLM. So this feedback loop actually goes on until we get the full history of the treatment timelines for every patient. The second flowchart actually shows you a clinical utility, how you can use these patient timelines. This is called clinical question-answer workflow. So it starts with a user query where, for example, a clinician asks what is the most seen adverse events for these patients treated with osimertinib. So this workflow will retrieve the relevant information from the patient knowledge graphs, in this case, which is like the adverse events, and often it also retrieves some external knowledge like NCCN guidelines or clinical trial outcomes which are available in different websites online. And then it creates a context and provides you or the user a well-reasoned answer along with the evidence which is traceable and auditable. So here, briefly I want to show you a dashboard which we are hoping to build after developing this pipeline. It's an interactive dashboard. The users are focused, like the focused users are the clinicians who can, see all these clinical events for a particular patients, which they can select on top. And after that, this section will show you all the corresponding evidences with exact note dates of the clinical progress notes and the lines from where the AI generated the answers. The next section is then comparative analysis among different patients. So yeah, they are also interactive. And the last section is a chatbot where clinician can type in a query and it will provide the answers. Yeah, so, and also the evidences. So as you can see here, it has pulled some NCCN guidelines, etc. Thank you.
Okay, hi everyone. My name is Sayeri Lala. I am a postdoc here in the School of Medicine, and I'll start by just giving a broad overview of my background. So in general, my research interests have spanned using AI, developing AI pipelines to make clinical workflows more efficient, and also just using them to improve consumer health outcomes. So I wanted to just kind of give a sense of my journey. Basically, my research really started when I was an undergrad at MIT in ECS, and there I had the opportunity to work at the intersection of AI for improving the quality of fetal brain MRI. There basically I had developed some kind of deep learning framework for assessing on real time how these images have artifacts and basically how we can use that to actually improve and reacquire these contaminated images. Afterwards, I did my PhD at Princeton, also in the electrical and computer engineering department, where I worked on using AI to make clinical trials more data efficient. So this was in two respects. One, reducing the total sample size that's required to run these really large-scale RCTs, and also reducing the amount of data that actually gets collected over the course of the trial. And then during my time at Princeton, also had the opportunity to do a couple of research internships with Apple on building predictive models from consumer health data, specifically wearables. And this eventually led me to do my postdoc here in the School of Medicine, where I work both in the Department of Neurosurgery, but also in the Quantitative Sciences unit, working with Professor Summer Han and some collaborators. And here my research has focused on how can we use AI to model long-term patient outcomes, both from wearables, but also multimodal EHR data. So for example, one of my projects right now is looking at how we can leverage both wearable data, patient-reported outcomes, and all the clinical data in order to assess whether patients from undergoing spine surgery, for example, what kind of recovery pattern will they have. So now I want to segue into talking about the kind of work that I'm doing in the context of cancer care. So first, here we're interested in the problem of how we can build a model to predict who's at risk for recurrence among non-small cell lung cancer patients. And just briefly on the clinical challenge here, the recurrence rates for these kind of patients is pretty high. It can range as high as 30 to 55% after undergoing surgical resection. And so there's clearly a need for developing a risk prediction tool that can guide not only surveillance patterns, but also whether somebody should receive adjuvant therapy or not. Now, if we take stock of the available models today, they're really just guided using very limited risk prediction factors. So for example, usually like histology, the type of histology of the tumor, and also staging information. But we're now at an era, right, where there's just so much data available that we collect from the patient. So for example, of course, like CT imaging, the pathology reports, all their vitals, et cetera. So we really want to harness all this information. And so that's exactly what my project is. So here we are developing a risk calculator that ingests all this rich patient information and use it in order to calculate the risk of developing recurrence, 5 years down the road, 10 years down the road. And in order to do this, we have basically put together a deep learning pipeline, one in which we're taking all this, it's multimodal, right? It's multimodal, it's time series based, but at the same time, it's challenging because there's a lot of, all the data is asynchronous, so it's highly unstructured. And so we've developed this deep learning pipeline, or we are developing, it's in progress, but we're developing this deep learning pipeline that is embedding all this rich data, and then we'll output the risk score for various causes. Of course, we need to account for competing events, and so that's why our architecture is appropriately accounting for that. And this whole model is being trained using an appropriate deep learning extension of standard partial likelihood losses. So happy to chat further about this if that's of interest. Thank you.
All right. Good afternoon, everyone. I'm Alan, and I'm a third-year biomedical physics PhD student at Stanford here. Previously, I was an undergrad at UNC Chapel Hill, studied physics and computer science. And so I was born in China, in Beijing. And during middle school, there were these mandatory morning exercises that happened every morning at like 9:30. We had to run around the track. And ironically, there's a PM 2.5 tracker just next to the track. So sometimes we couldn't even see the tracker. So that was the main reason my family moved to North Carolina after my middle school. I'm fortunate to that my family had a means to move to North Carolina, but I'm still thinking about people who have to suffer through the air pollution, and this work is really important to me, and I'm grateful for the opportunity to contribute to this work. This is on chest X-ray dose photon counting CT for lung cancer screening, spearheaded by Dr. Louis and Dr. Guo and Carolyn. So for background, you've heard about these things many times over the past 2 days. Lung cancer screening reduces mortality by detecting and treating early-stage lung cancers, and the low-dose CT is one of the prominent tools for lung cancer screening. However, there are multiple challenges with low-dose CT for lung cancer screening that limits the screening criteria. And the focus of this project is to target the concerns over radiation dose. So recent developments in CT may enable ultra-low dose CT for lung cancer screening, and in particular, photon counting CT may enable chest X-ray equivalent dose. So to put into perspective, this is about the same as a round-trip international flight, for example, from SFO to Taipei. So the main objective of this study is to evaluate the performance of chest X-ray dose photon counting CT compared to the routine lung cancer screening dose, low-dose CT for lung nodule detection. And so 21 lung nodule follow-up patients underwent paired lung cancer screening and chest X-ray dose chest PCCT, and the recruitment is ongoing. We have about, I think, 40 subjects for now, and more recruitment is ongoing. And the scans were done on the Siemens Neoton Alpha scanner. So a senior thoracic radiologist established a reference standard from the routine lung cancer screening dose scans, and we focus on the clinically significant nodules defined as solid nodules greater than 3 millimeter and ground glass nodules greater than 5 millimeter. And then a deep learning-based nodule detection algorithm was applied to both doses. And we compared the nodule detection performance between the two doses. For results, here's a qualitative visual of the lung cancer screening dose PCCT image and the chest X-ray dose PCCT image. So in terms of radiation dose used, the average dose was about 10x less compared to the routine lung cancer screening dose. There were in total 76 clinically significant nodules from the reference standards, and 73 of them were detected by both scans, and one was detected only on the lung cancer screening CT, and one on the chest X-ray CT, and one by neither. So the sensitivity was greater than 97% for both those scans. And the conclusion was the detection of clinically significant permanent nodules on chest X-ray dose PCCT was comparable to lung cancer screening dose PCCT. And I have more details on the poster on slide number 13 later this afternoon if you want to know more details. Thank you.
All right. So hello, my name is Nieda. I am a research assistant for Dr. Summer Han. And to give you a brief background about myself, I started my education, undergrad education in Japan. I attended International Christian University and the University of Tsukuba, studying a lot of experimental biology. And I spent 4 years, and I had the time of my life over there, and engaging with the people and then the culture and of course the different research perspectives. After graduating, I came back to the US, the Bay Area, where I grew up, and before coming to Stanford, being the Silicon Valley, I decided to join join the startup tech industry, and so I spent around a year or two as one of the founding software engineers here at Tech4Rights. And it was here that I really realized my interest in data and the analysis and like the data manipulation. And so and a lot of the decisions, especially in business, are data-based, and they're not purely vibes. And so I reached out to my current PI, Dr. Summer Han, showing an interest in biostatistics, and found myself researching a lot of lung cancer. So one prominent study involving never smokers with lung cancer, we've been trying to develop methods in order to create a composite score that will allow us to estimate the tumor burden for lung cancer patients using their CT and MRI reports. And additionally, we've also been trying to utilize some of the modern technology and developments in large language models in order to help label the data and to give analysts a little bit more data to work with. And so we intend to utilize this score for risk stratification and hope that it will be helpful for clinicians and oncologists to guide treatment decisions. In the future, I do hope to continue doing this, building on my research experience, pushing kind of the forefront of personalized medicine and an early detection of diseases. And I do not have any figures from my study, but if you would like to talk to me more about it at the poster session later, I'd be very happy to. Thank you very much.
Hi, my name's Emily. I'm a current fourth-year undergraduate student here at Stanford University, majoring in human biology with a concentration in cancer biology and human physiology. I'm also interested in pursuing a master's degree in the epidemiology department. My results hopefully come out soon, so wish me luck. And I focus with a concentration in health equity and community engaged research with the end goal of potentially pursuing an MD PhD as well. So I'm currently an undergraduate researcher for Summer Han, and my current project is incidental nodule follow-up among never smoker Asian patients. So my study is specifically looking at the lung cancer recurrence in after incidental nodule detection. So the goal of my study is to evaluate early detection mechanisms for screening ineligible and high-risk never smoking individuals to provide insight for potential screening in this population. Doing so, we're using radiological reports from electronic health records to curate detailed nodule characteristics and imaging performed from time of incidental detection. I'm also evaluating if there's an association between the intensity of your follow-up and the incidence of your nodule detection and your outcome among your Asian patients with no smoking history. And to do so, we're using longitudinal electronic health records, working with generative AI and developing large language models, and using rigorous epidemiological methods. Thank you.
Hi, my name is Lydia. I'm currently a freshman studying biomedical computation. And just a little bit about me, I'm from the Eastern Shore of Maryland, and I've previously worked at the Women's Health Integrated Research Center at INOVA on a cancer proteomics lab. And I've also worked a little over 2 years at Moffitt Cancer Center in their integrated mathematical oncology department, and that's really where I fell in love with just using biostatistical methods to treat cancer. And now I'm here working in Dr. Summer Han's lab, and the first thing that I'd worked on with Dr. Han that I'd actually gotten interested in were these socioeconomic indices, which is actually, one of them is the MAP. It's the Area Deprivation Index, and looking at the current problems with them and trying to validate them. They are currently being used for federal reimbursements for healthcare. And right now, my work has switched over toward focusing more on lung cancer specifically. What I'm looking at right now is trying to optimize post-osimertinib lung cancer care with generative AI and dynamic landmarking, looking at osimertinib specifically, which is used to treat the T790M mutation for EGFR positive lung cancer patients. And after progression, clinicians usually run some tests to determine what the best next course of treatment would be for those patients. However, that time in between stopping osimertinib and looking for the next treatment, the patient is kind of in limbo, and we want to gather data about what's actually going on there and what is the effect on the patient. So the pipeline shown here, we're looking at the clinical notes and gathering data. We would like to create a large language model to extract that data and automate it for down the line. And then we will apply the dynamic landmarking model to predict 90-day time to next therapy and 120-day 180-day mortality. And I'm very honored to be here, and thank you so much for your time.
Hi, everyone. My name is Annabel Tan. I am a data scientist. I'm a trained epidemiologist working with Dr. Summer Han. I also work with the Cancer Data Science Core, which is an initiative that she, Dr. Han, and Dr. Kurian both lead. We have a lot of data, so come work with us. So I got my PhD in epidemiology here at Stanford. And before that, I worked a bunch of public health jobs. I got my MPH actually in epidemiology at Yale quite some time ago. But yeah, I feel like my career has sort of led me around different areas of epidemiology. My PhD, for instance, was in cardiovascular health and environmental, looking at environmental exposures on cardiovascular health. It sort of led me full circle now. I work in cancer research. My family has a history of cancer. My dad actually passed away from it many years ago. One of the key projects that I'm working on right now is to leverage large language models to identify CT imaging indications for post-treatment for patients who've been treated for lung cancer. And so a little bit of background, I think, so surveillance guidelines typically recommend chest CTs for folks who have had lung cancer every 6 to 12 months among those who have early stage lung cancer. And because, the chances of recurrence are pretty high, like 30 to 50% among people who've already had lung cancer. However, I think CT scans, as a lot of people in this room know, are performed for a lot of reasons. There can be for surveillance, a symptom evaluation, so that means you come in and then, because, you've had like a bloody cough or shortness of breath, or you can also come in for a metastatic follow-up, which means that you're currently on some sort of systemic therapy, and then you come in and get a CT done for that. However, in EHR though, this is not sort of shown in EHR or anywhere in the records, and so this kind of complicates sort of how we look at how well a patient is adhered to their, to how often they're being followed up for CT imaging. And then it's also not great for estimating survival outcomes. And so this is why, why we think that using LLMs to estimate, to sort of classify imaging indications can be useful for sort of refining outcomes. And so in our cohort, we have about 1,500. I didn't list them down here. They're on my poster for more details. We have about 1,500 patients in our cohort that we have extracted CT indications from. And I think, we use, we tested a various bunch of LLM models in them. So the latest, like GPT-5, Gemini 2.5, O1 models. So we've tested our prompt on all of them to see how well they can basically classify the CT indications. And so we want to be able to sort of use this as well to sort of inform clinical utility. And so we also are going to carry out survival analysis and test how well these LLM predicted indications do in regression models. And so I have the results of those on my poster. It's at poster 13. And yeah, so that's today. Thanks.
right, if we have any questions from the audience, please feel free. I'll get us started while everybody thinks of their questions. Thank you all for your great presentations and for giving us a flavor of all the things that you're working on. I'll try and kind of bucket the questions. So this one will be directed at Jackie and Alan and Carolyn. You guys talked about projects implementing things with patients. Talk a little bit about what challenges you faced and how that sort of informed your approach to research going forward.
Thank you for your question. So joining this team and conducting the molecular imaging trial has definitely been a really wonderful learning experience, but what I think was really profound was just research takes a lot of effort, both from the research team, but also specifically from the patient side. So thank you to all the patients who have contributed to science and been willing to participate in research. For the Pan 800 trial specifically, it requires extra time for infusion, blood draws, extra clinic visits. And so moving forward with research, number one, I have so much appreciation to the patients who agree. And number two, trying to find ways to streamline these efforts so that it is less burdensome for the patient.
One of the challenges that we encountered when we were doing our multi-center study and really trying to evaluate, this patient subgroup, patients with EGFR mutated lung cancers who are getting this standard of care treatment, chemoradiation followed by durvalumab, is that, molecular testing has been established in the metastatic setting quite well. I think there's been a lot of education, a lot of teaching that's been going on. But what we found was that a lot of people weren't testing for molecular alterations in patients with lung cancers that were diagnosed in the early stage setting. And so actually that's why our initial study was quite small, is because a lot of centers weren't doing this testing, with one of the main reasons also being is that a lot of it wasn't reimbursed through insurance. So it was actually quite challenging to find these patients. It's a very specific patient population, stage 3 unresectable. But, with our efforts, we were able to show that, that there is a lack of benefit with this treatment strategy that was ongoing at the time and potential harm. So I think that just goes to show, the importance of molecular testing. So we did, and even in the early stage setting. So we published an editorial on this. We've been doing a lot of advocacy and teaching. And certainly this has been helped with the new trials now that have established adjuvant osimertinib as their standard of care for, surgically resected lung cancers as well as with chemoradiation. So there's definitely a lot of movement towards that, but we're still doing a lot of efforts for teaching and advocacy for this because we can't study something unless, patients have been tested, right? So I think this also applies more broadly even beyond the EGFR space to other kind of rarer alterations.
So for the project I talked about, I'm actually less patient-facing, where Carolyn, I think, and Jake were the people who were calling the patients and then signing them up for a chest X-ray dose, PCCT. But I was actually talking to Carolyn last night at the dinner, how these calls happen, and I think a lot of it is education on the patient side for what are the actual risks of radiation at what dose, and what are the benefits of getting this either low dose CT or chest X-ray dose CT, and how does that compare to the radiation risks?
And Alice, I think it was you who talked about working with families. What unique barriers did you encounter there?
Great question. Thank you. I would say that it wasn't necessarily considered a barrier so much as actually a really positive and useful thing to engage families with interventions related to smoking cessation. And I think it's because family members of these men in particular were really, really motivated to get their husbands or fathers or whoever the family participant was to quit smoking. And so I would say it was more of a motivation for people to participate rather than a barrier.
Fantastic. Any questions from the audience? Yes.
I could be wrong, but it seemed like half of you had AI projects. Is that about right?
2/3.
Two-thirds, maybe two-thirds. So rather than talking about potential benefits of AI, what are your concerns about AI, either in your area of research or professionally? Maybe start with the people who had AI projects, or maybe start with the people who didn't have AI projects. Up to you.
Yeah, that's a great question. I'd love for those of you who spoke about AI and generative models and LLMs to answer.
So the first concern about using AI, thank you. First concern about using AI in clinical projects is, of course, we have to very cautious and consider safety first, because AI models, no matter how intelligent they are nowadays, irrespective of Gemini, ChatGPT, etc., Claude, Grok, etc., they all have the tendency to hallucinate. So when you provide, so AI cannot, so the main characteristics of AI pipeline is you feed some kind of information, and then based on your question or criteria, it will provide an answer to it. But sometimes it happens like the information that you have fed to it, it's something else, and AI has created something which is completely new and out of that evidence and gave you a false answer. And it can have some serious implications when you are working with patient data. So one way to target this kind of hallucination and reduce it, to generate or to provide or to request evidence from the LLMs or generative AIs, where this evidence are the exact note excerpts from the information that you have provided, so that you can compare what AI has answered and what the actual or original document has said. So you can trace whether the LLM has hallucinated or not. So yeah, that is something which popped in my mind for first, and if anything extra anyone want to add?
Yeah, I can piggyback on that. So for my, so again, just to as a brief reminder, I'm working on these risk prediction models. And so we've been thinking about evaluation of these models. We spend a lot of time actually thinking about how we're gonna make sure that this is really ready to use in the clinic. So for that, in these kind of AI setups, you have your internal development set, which you use to actually train the model, but you can also use it to validate. But at the same time, we also want to make sure it generalizes. And so for that, we're going to be using the Sutter health data to actually see, okay, is this model, sustaining whatever AUC we see on our internal set? We're also evaluating different kinds of metrics. So it's not just about AUCs, for example, which a lot of papers tend to just focus on. But we're also looking at how well calibrated these risks are, so that they're actually meaningful to interpret from the clinician side. And there are other kinds of clinical utility metrics that can also give you a sense of for every true positive, there's always a trade-off, right? There's going to be some false positives. So how does that really translate in the clinical care practice when you actually deploy this model? So I think basically my point being you should be cognizant of the kinds of evaluations that you're doing, because I think a lot of these papers that get published, they just look at very kind of simplistic setups and don't really think about rigorously how to evaluate.
I have a follow-up question about sort of accuracy of the models and predicting clinical outcomes. So what do you envision? Where are we going to someday see a patient in clinic and have a binary answer? Yes, your lung cancer will recur in 39 months. Therefore, in 30 months, we should start you on systemic therapy. Or do we have a long future ahead of us of 8%, 12%, 50%? It's very hard for patients to incorporate statistics like that into their decision making. So what can we hope for?
I would say, no, definitely AI alone is not efficient in making this kind of binary decisions for patients. We always need doctors and specialists who have, researched for years with this patient history and patient profiles. So yeah, we definitely need their opinions. AI, what it can do at best is help the doctors or clinicians gathering all the relevant information about, different criteria, different conditions, or related clinical trials, what are the outcome of those clinical trials, what were the inclusion-exclusion principles of those clinical trials, etc., so that the clinicians, they don't have to engage more time or invest more time in gathering those evidences. So it can help a clinician at best, but I don't think that AI would be, that expert who can take the decision all by itself and, engage in, patient decision making. I think doctors are really important in that process.
I will add a separate point. So first of all, the word AI is super overloaded right now. What do we mean by AI? So I was actually a CS undergrad before the ChatGPT era. And then back then, AI was the convolutional neural networks, and before that was the multi-layer perceptron. And even linear regression is the first thing people talk about when talk about AI. And now it's mostly LLMs and the ChatGPT and the cloud. So I think the rate of technical progression or the timeline sometimes doesn't really line up with what we're trying to do with the clinical deployment, where if we're talking about deployment, it's usually like on the order of a few years or something. And for a research paper, it's like a couple months to a year. And then for these newer models, they're coming up with a new model every few months. So thinking about putting the effort into using or deciding which model to use, I think is something to be conscious about, because after a few months, there could be another model that just beats everything that you did with the previous model.
Sorry, if I may. Yeah, I think it kind of depends who you talk to. If you want to answer the question, like, will AI eventually replace doctors? Like, I think if you talk to like the more progressive think, like, they'll be like, yeah, it will. I was like, no, I don't think anyone in this room will agree with that. That being said, I think one of like the things that are actively happening now is, I think people are trying to use LLMs to diagnose a lot of cancer cases and stuff like that, but like whatever comes out, and like we've all tried it, I think is a lot of, as Rittwika said, a lot of garbage, and it takes a lot of expert knowledge to sort of parse through that knowledge, and I don't think we're quite there yet. I'm not sure how far away we are from like having the AI accurately parse through all that stuff, but I mean it's good, but I don't know how far away we are yet.
Just going to add, like, your question about a binary classification, sort of a fundamental aspect of statistics is studying and quantifying uncertainty. You can't eliminate it. So even if in the end you make a 0-1 decision, there are error bars or uncertainty around that. It's just in clinical decision making, you do have to make a decision at some point. And I think part of what gets masked in using these models is it masks the underlying uncertainty because they're very confident and they will speak to you like they know what's going on. But I think anyone who's familiar with the underlying science and the studies and the statistics knows that no good scientist ever says something is absolutely for sure true. You have uncertainty, and uncertainty is a healthy part of being a scientist.
It's a great point. I think we have time for one last question.
Oh, last question again?
Yes, no pressure.
All right. So I just want to follow up on the AI safety side, and I heard two sort of potential solutions to this. One is you dig into the facts, try to verify, and the other is using benchmarking. Now, on digging into the fact, how scalable would that be? Because if you have to verify every answer, it's not really feasible, right? So that's one. And then the other is on the benchmarking side. How do you know it is rigorous enough? Because we have seen research where when you tweak the benchmark a little bit, the LM performance dropped by 20%, right? So how much, can a clinician trust the benchmarking results when you show that to them? So two related questions.
I can answer the first question. A lot of my work is about handling the data and labeling it manually first, and then we allow the LLM to make inferences or their own labels, and we'll check one-to-one every single note if it's correct or not. And a lot of my early work has been focused was how we used to do it before, which is all manually. So you look at the note, you look at the instructions that someone, like the guideline that someone has written for you, and you do it yourself. And one of the kind of rule of thumbs that we've practiced, at least in our lab, we've set aside usually, for some data is like over 1,000 manual annotations, and we try to get the LLM to have around 90% or above accuracy, which is about the same error rate as a manual annotator. And we kind of make the assumption there that if we scale this to a full data set or to the whole healthcare, all the patients, that the accuracy will remain at around 90%.
I think we probably have to stop it there for time, but thank you all so much for your presentations and sharing your stories. I think we can all agree that the future of research in lung cancer is very bright. So thank you all.